Welcome to my podcast, Diet, Disease, and Doctor Dialogues. In this episode, you can listen to an urgent care physician discuss the realities of living with diabetes, from what a prediabetes diagnosis really means to treatment options, insulin management, and the causes of high morning blood sugar. We also explore the serious risks of leaving diabetes untreated, the most common emergency seen in the ER. Whether you've newly diagnosed, caring for someone with diabetes, or just curious, this conversation offers clear, practical insights straight from the medical front lines. Stay tuned for the next 30 minutes to learn about the ins and outs of diabetes. Welcome to Diet, Disease, and Doctor Dialogues. Today I'm with Dr. Faleka. Thank you so much for being here today. And before we get started, would you like to introduce yourself?
Sure. I'm Dr. Anna Faleka. I'm physician at Mass General Brigham Urgent Care, Boston, Massachusetts.
Right. Let's get into our questions. First, diabetes, as we know, is a progressive disease, and when a patient is diagnosed as pre-diabetic, what does that mean for them in terms of medications, diet, and lifestyle changes? And how seriously should that pre-diabetes diagnosis be taken?
So diabetes is a serious chronic medical condition in which blood glucose is high, and this high glucose level becomes toxic. Um, Diagnosis of diabetes, and we first talk about diabetes, and then we go to talk about pre-diabetes. Diagnosis of diabetes established if fasting blood glucose in plasma is more than 126 milligram in deciliter. Second criteria, if random blood glucose is higher than 200 milligram per deciliter, or third criteria, if elevated hemoglobin A1C more than 6.5%. So American Diabetes Association defines diabetes as condition in both glucose is underutilized or overproduced. So one of the main regulators of glucose or blood sugar is hormone produced by pancreas called insulin. There are also other hormones that help to regulate blood glucose, and we can talk about it later, but insulin is the main regulator. So there are different types of diabetes. Type 1 diabetes is in which autoimmune destruction of pancreatic beta cells causing absolute insulin deficiency. Type 2 diabetes is when there is insulin, but it's in inadequate amount, and insulin resistance by body cells. So insulin is not effective as in patients without diabetes. And small category group, but also not infrequent, gestational diabetes, which is diagnosed during pregnancy, diabetes related to genetic disease, pancreatic disease, and drug-induced cases. So chronic blood glucose elevation is damaging to blood vessels, to nerves, and heart, kidneys, and acting as a basically toxin. So now when we discuss what diabetes is, we can talk about what is pre-diabetes and why pre-diabetes separate in different groups. So as it comes from the name, pre-diabetes, something that, pre-occurs diabetes is when blood sugar level elevated above normal, but not high enough to meet diagnostic criteria for diabetes. So blood glucose levels elevated, but not that high that we name it diabetes, but it's kind of in the border. So diagnostic criteria for prediabetes are fasting plasma glucose between 100 to 125 milligram per deciliter, Second criteria, 2 hours plasma glucose during 75-gram oral glucose tolerance test, 140 to 199 milligram per deciliter. And third criteria, hemoglobin A1C, which is average blood sugar for 3 months, is between 5.7 and 6.4%. So to have diagnosed prediabetes, you can meet just one of the mentioned criteria. Why we talking about prediabetes and concerned about it? Because it is a significant risk factor for progression to type 2 diabetes. And for cardiovascular disease. So it's not only precursor for diabetes, but cardiovascular disease. It should be taken seriously because at this stage, the changes are reversible. So in prediabetes, changes are reversible. Unfortunately, when you have diabetes, the changes already are irreversible. So you can only maintain, blood glucose. But if you manage prediabetes, you have very high chance that you never develop diabetes. So in prediabetes, blood glucose and carbohydrates metabolism already impaired, and blood glucose, although higher than normal, but below the threshold for diabetes, as we talked just a minute ago. So this impairment is due to combination of, number one, insulin resistance, number two, beta cell dysfunction in pancreas, which leads to inappropriate endogenous glucose production. And beta cells, and there are also other areas of organs where you have production of, or should I say other organs where you have production of glucose, like liver, like muscles and fatty tissue, when we have storages of glucose, but due to gluconeogenesis, glucose also can be produced. So these regulations impaired during prediabetes and through the progresses in diabetes. As well, the other causes is decreased hepatic glucose clearance and delayed glucose uptake in peripheral tissues. So main intervention at this stage is lifestyle and diet changes. And there are some medications that we can use to help with, lifestyle changes and exercise work more effectively. But it's not medication at this point in prediabetes are not the mainstay of the treatment. So what are the lifestyle interventions? Focusing on weight loss, dietary changes, increased physical activity. So all this can lead to regression of prediabetes. Now, medications that we use in diabetes sometimes could be used as well in prediabetes, such as metformin.
That was a very thorough description. And from that, like big picture, like type 1, type 2, gestational, and pre-diabetes, let's zoom more into type 2 diabetes. And as you mentioned, people with type 2 diabetes still produce some insulin, and there are several oral medications available. Could you give an overview of the most commonly prescribed drugs and how physicians determine the best fit for a particular patient?
So first-line medication for type 2 diabetes is, we just mentioned, metformin, which could be used also for pre-diabetes, but if we talk about diabetes type 2, and right now we're talking about diabetes type 2, when insulin production still functions, but just decreased and not as effective. So medication, first line is metformin, and the metformin belongs to class of biguanides. So what it does, it decreases intestinal absorption of glucose in the gut. It's decreasing hepatic glucose production, which we touched a little bit earlier. So it's a process called gluconeogenesis in the liver, which synthesizes glucose from storage, and metformin decreasing this way of increased glucose in the blood. It also improves insulin sensitivity through increased peripheral glucose uptake in the tissues like muscles and adipose tissues, just like we discussed. And it helps to absorb glucose from the bloodstream and utilize it for energy, therefore decreasing blood sugar in the plasma and blood. So net result of this function is improved insulin sensitivity and increased glucose disposal in muscle and fat, so which helps to lower plasma glucose level. Side effects, there are some side effects. Unfortunately, most common nausea, diarrhea, vomiting. It also contraindicated in patients with low kidney function. But side effects typically tolerable in most cases and go away as you get more acquainted with medication in a week or so. So second group, and I know we were talking about drugs and medications, oral medications, but this group I wanted to mention, it's very important and very recent and become very rapidly popular. It's group GLP-1 receptor agonists, which is what it is. It's glucagon-like peptide 1 receptor agonists. They work by mimicking action of endogenous glucagon-like peptide 1 produced in the gut, which belongs to group incretin hormones. And the examples of medication is semaglutide, which also widely advertised as Zepbound, Wegovy, Ozempic, liraglutide, and dulaglutide. So these medications should be injected subcutaneously once a week. There's only one medication that can be taken orally in this group, is semaglutide. So the popularity to these medications also due to help with weight loss. So they increase glucose-independent insulin secretion, they slow stomach emptying, and reduce appetite and energy intake, leading to improved glucose control and weight loss. If we continue to talk about oral medication, and we're going to talk for type 2 diabetes, next groups of oral medications. Another very now common used group is sodium glucose cotransporter 2 inhibitors, such as Jardiance or the brand name empagliflozin. Empagliflozin is the generic name, and Jardiance is the brand name, as well as in JAK2 diet and exercise. So how this group of medications work? It works by inhibiting glucose reabsorption in renal tubules in kidneys, and therefore it increases loss of glucose with excretion and lowers blood glucose levels. It also been approved to reduce risk of cardiovascular death in adults with type 2 diabetes and reduce risk of worsening kidney function due to diabetes. Usually this pill is taken once a day, and side effects are frequent urination, yeast infections, and dehydration. Fourth group of medication used for diabetes type 2 treatment is DPP-4 inhibitors, which is dipeptidase 4 inhibitors. They work by inhibiting DPP-4 enzyme, which slows the inactivation of incretin hormones such as glucagon-like peptide 1. So basically, it works in similar fashion as GLP-1 agonist, but inhibiting different type of enzyme. And again, results in prolonged level of incretins, and which are hormones enhancing insulin secretion, helping lower glucose. And the name is sitagliptin, brand name Januvia. Fifth group for treatment of diabetes is the oldest group out of all. It's been used since last century, mid-century. It's called sulfonylurea, which is glyburide and glipizide. And they work directly by stimulating pancreatic beta cells to increase insulin production. Now, with that, it also increases risk for hypoglycemia, and this is why it's used less often now, just due to that risk of the side effect of lowering blood sugar too low. And answering question, how do we choose which medication? So basically, like I said, first line is metformin, and you just see how patient tolerates it, and if there is any contraindication, such as a low kidney function, then we're probably gonna try a different class. If patient struggles with weight loss, then we can try GLP-1 agonists as well as for cardiovascular prevention. If a patient has again high cardiovascular risk and kidney disease, maybe started on CGLT2 inhibitors, sodium glucose cotransporter inhibitors. They inhibit absorption in the kidneys. So it also all depends on what other level of comorbidity, the tolerance, patient tolerance it, side effects profile, and also, of course, you look like if that's on the efficacy of this medication. Sometimes we have to combine few medications together to achieve better result.
When that insulin becomes necessary for a patient, how can they monitor their blood sugar and administer this insulin efficiently? Are there best practices or common mistakes patients should be aware of?
Yeah, so there are different types of blood glucose monitors, such as blood glucose meters, and there are also continuous glucose monitoring devices. Blood glucose meters are portable devices that use capillary blood obtained by finger stick to provide point-in-time glucose measurements. They recommend it for individuals, especially on a high intensive insulin regimens, because you might want to check what is your blood sugar at the point of time at this moment. Continuous glucose monitoring systems use, so these are subcutaneous sensors which attach to subcutaneous tissue to measure interstitial glucose every 5-15 minutes and providing either real-time or intermittently scanned data, trend information, and alerts for hypo or hyperglycemia. So there are different types of insulin, and depending what type of insulin you're using, you also have different regimen of injections. There are long-acting insulins, which can be used or should be used once a day, subcutaneous injection. There are also intermediate action insulin, which, for example, could be injected twice a day, every 2 hours. There are also a group of fast-acting insulins that need to be injected before each meal 3 times a day. So this also different definitions for insulins, which is basal insulin or prandial insulins. So it is basal insulins usually tries to control insulin that produced at the base level. Pretty much everyone produces insulin continuously, and body knows how to regulate it, which is lost in diabetes. So for that we use basal insulins, which are mostly longer acting, but sometimes blood glucose is more affected by meal intake. So for that cases, we use prandial uh, insulins, or we also call bolus insulins. So again, if you want to cover basal insulin, basal glucose elevation, you use basal insulins, which are typically longer acting, and once a day, or if you want to cover elevation of blood glucose after a meal, you use bolus or prandial insulins. So there are also fixed doses, combination insulins, premixed insulins. Um, bolus insulin refers to short or rapid acting insulin, which administered at meal times, and typically they are added when blood glucose target are not achieved with just basal insulin and plus oral agents for blood glucose lowering. And bolus insulins that cover meals, they are associated usually with high risk of hypoglycemia, so have to be used shortly before meals, or if it's rapid acting, just right before meals, right during the meal.
When I was researching, I found it common for people with diabetes to experience high blood sugar levels in the morning. Could you explain the underlying causes of this and clarify terms like dawn phenomenon and Somogyi effect?
Right. So dawn phenomenon is an early morning rise in blood glucose, typically occurring between 2 and 8 a.m. In the absence of preceding nocturnal hypoglycemia. So it is most commonly seen in individuals with diabetes, and it's characterized by increase in fasting glucose or insulin requirements during this period. The underlying mechanism involves circadian driven increases in insulin counter-regulatory hormones or blood glucose regulation hormones, which actually increase blood glucose, such as growth hormone, which is released at night or early morning, and as well as cortisol. So these hormones tend to increase blood glucose, and therefore it increases blood sugar when their production most highest during early morning hours for glucagon, and it leads to high blood sugar in the morning. So usually it might be also affected in people's diabetes by circadian clock disruption, poor sleep quality. All this can worsen dawn phenomenon. And Samagu effect, which is fasting hyperglycemia, followed antecedent nocturnal hypoglycemia. So what happens, you have lowering blood glucose during night, so to speak, during this fasting period, and it causes counter-regulatory hormones increase your blood glucose. So blood glucose levels elevated, and one develop hyperglycemia, and it present in approximately half of patients with type 2 diabetes mellitus. And to optimize it, we have to adjust basal insulin long-acting insulin, as well addressing lifestyle factors such as sleep quality and meal timing.
But if a patient didn't manage their diabetes as you described, what are the risks of leaving diabetes untreated, both in the short and long term?
Right. So there are short-term complications, meaning that develop right away. It can happen at any moment. One of the most common is and mostly it's metabolic emergencies. For example, one was most common is diabetic ketoacidosis, or sometimes people call diabetic coma. The other types of coma or emergency diabetes, hyperglycemic hyperosmolar state uh, due to dehydration, severe dehydration, or hypoglycemic coma when blood glucose level dangerously low. Other acute complication could include infections, which are very common in people with diabetes, and partially due to impaired immune function. Long-term complications, it's eye damage, blindness due to damage of blood vessels in the eye and different other mechanisms causing blindness, kidneys failure, peripheral and autonomic nervous system damage. Again, it's probably not something they can develop right away, but it develops as long as diabetes persists, or sometimes the damage can actually preclude developing diabetes. It's not very common, but can happen. So people sometimes can develop this nerve damage, what we call neuropathy, before developing diabetes. As well as we talked about infections and due to damage of blood vessels can cause amputations. And the other long-term complications, obviously, is cardiovascular disease, such as stroke, heart attack. Also, in the past decade, there also noted some increased risk of cancers, including pancreatic cancer, liver, colorectal, endometrial, and breast cancers. Have been added to traditional vascular complications of diabetes.
To end our discussion, I wanted to probe your perspective in emergency medicine and what are the most common diabetes-related emergencies you encounter in the ER?
So, diabetic ketoacidosis, most common, but hyperglycemic, hyperosmolar coma, and hypoglycemia also acute life-threatening conditions, quite frequently presented to the ER. Cardiovascular life-threatening conditions, as we discussed, such as heart attacks, strokes, very often associated with diabetes. Infections, such as skin infections, and not only skin infections, associated with microvascular complications of diabetes, occasionally present as emergency as well to the ER. So these are examples of some cases of diabetes complications that we see in ER.
Wow, thank you so much. I know I learned a lot, and I'm sure our viewers will too.
Thank you very much.
That brings us to the end of the episode. Today we've unpacked what it means to face diabetes at different stages, how lifestyle choices, medications, and insulin all play a role, why blood sugars can fluctuate, and what happens when the condition is left unchecked. We also touched on the urgent situations that bring patients to the ER. I hope this episode has given you the knowledge to better understand this complex disease and its impact on everyday life. For now, remember to stay curious, stay safe, and until next time, this is Naomi Faleka, signing off from Diet, Disease, and Doctor Dialogues. See you soon!